So again, disclaimer is that a lot of my works have actually been done by Dr. Ashok and Dr. Mahesh. So this is not legal advice, and everything that I quote here, especially some of the cases, are in the public domain, so I have nothing against any colleague or even the legal profession. So we are in the changing times, I think. The idea is to remember that that sacred doctor-patient relationship unfortunately has been eroded, and we now have to pretend that almost every case can actually be a litigious case. I'm on one spectrum because of ROP, as you mentioned. Probably not only the case load is large, but also the duration in which you might have to fight these cases and get punished for these cases go for a very long time. Having said that, the principles of ROP will apply for the rest of ophthalmology, and I'm trying to weave in some of the principles into my talk. This has already been mentioned by Dr. Ashok. So there is negligence, unethical acts, and misconduct. So we know a lot now about negligence. We know that it comes under IPC, TOT, and so on. But there's also a new code of ethics. So Medical Code of Ethics 2021 is now recognized as law. So now you can't say that you have to be a good doctor and a good surgeon and you shouldn't do wrong things and you shouldn't take money from cut practice and that's just a nice person to be. No, it's a nice person to be. But now if you don't do all of that, you can be prosecuted. So my point is we now come, even our ethics and our misconduct is now prosecuted because the code of medical ethics is now recognized as law. So you can actually go not only in the state forum or the national forum, for me it's Karnataka Medical Council, for you it's Kerala Medical Council, but you can actually take it up to the civil courts. This has been mentioned. What is duty? So our duty as ROP physicians or anyone, it begins when we take on the patient. So in ROP it is very different because our patient becomes our patient only when the neonatologist sends to you. Out of the 7 cases that have gone against ROP and one more in Gujarat Rajasthan last month, all of them have gone against the pediatrician. One of them has gone against the ophthalmologist as well. So as soon as we get involved, then we become liable. So that's important. And how long we continue until, and there's a way, either you cured the patient or in a bigger specialty the patient has died or the patient has decided not to come back to you. So there is something that's called where you stop your duty of care. If you have called a patient who requires, let's say, laser treatment for ROP and it becomes now your liability and you've informed, you must document that information, whether it's a phone, a message, an email, all of that has to be documented. Now after 3 repeated attempts, they say, I'm not going to come. The best thing you can do, and I have done this in a few cases, is to write a letter saying that my duty towards you has ended. And we have actually registered, posted that letter to the address provided to us in the hospital. Because tomorrow if the patient goes blind, I'm sure they unfortunately will because it was zone 1 disease, they will come back and say, they never called us, they never told us the seriousness. And unless you have documented all this, so this is basically that. Now dereliction of course means that you've gone against your duty, and as clearly mentioned, today our courts are taking not just BOLA but BOLITO as well. So we have to be really careful about how we are going, where we are going. These are the 6 most common causes of litigation in ophthalmology in India right now. Number 2 is ROP. So all these years ROP was somewhere, was not even there on the list. Number 1 is still post-op end-off and still camp-related cases, which of course we have now guidelines and most of us don't do camp-related cataract surgeries. So let's now talk about the second leading cause, ROP. And again, draw principles for that. Even if you all are don't doing ROP, you can sort of translate to what you all are doing in your specialties. So this is one of the largest, setbacks in litigation history. It was 1.8 crores, including the court fee. And this patient went from being a 3-month-old child to an 18-year-old adult. So it went from state forum to national forum to the High Court to the Supreme Court. And not just it did this open out Pandora's box, but it also pulled out a set of formulae on how the court is going to calculate what your compensation would be. And as rightly mentioned, it's not got to do with the age, but also what your parents do. For example, if the parents of the child are postgraduates, then it would be assumed that this child would have some level of education and standing in society, contribute at some level, and therefore the compensation of this person would be calculated that if he was not blind, he would have done this profession, earned this much to society, and all of that for 25 to 35 working years into interest and taking care of inflation will be your compensation. No, but this is a formula. If you read that 85-page judgment on this case, it is pretty scary because it looks like a sheet from a mathematics textbook. And now obviously that has become law. Now these are the very small print, but this is there both in the VRSI journal and now we've published it as well in a peer-reviewed journal, Asia Pacific Journal, where we have analyzed the other 6 cases for which went against doctors in ROP litigation. And what I summarize here is all those judgments that went wrong, and you can now translate it to the subspecialty that you take care of. For example, we're talking about consent. Now many of us do combined surgeries. We do cataract and vitrectomy. The vitrectomy surgeon's consent has to be different. How many of us do that? If there's an IOL drop, the retina surgeon from the next OT is called in to fish it out. How many of you all know that you have to take a consent separately of the retina surgeon? Because in the Samira Kohli case, one of the 10 tenets is mentioned is that the patient has a right to know who the operating surgeon is. As far as he or she is concerned, you are the cataract surgeon. You called in your retina colleague, patient doesn't know. Tomorrow there's a complication because of the retinal surgery, you will be liable, not the retina surgeon, because you never bothered to take that extra consent. So actually 2 consents have to be taken. When we are talking about waking a patient up from anesthesia and postponing the surgery, we are under topical anesthesia at best. So where is the justification for us to say that, a patient was under drape and so I decided not to take the consent? So, these are things to talk about. Not all of these have answers. So this is, I'll skip on this because this is where the pediatrician is. Now let's go to what the ophthalmologist, where the weak links, what the courts have found. So inadequate, inappropriate and improper. Now all these 3 are really important words. We won't get into the detail. But let's say we're talking about a screening visit. It could be glaucoma. In a case that I know of, mitomycin C was prescribed after a certain surgery, but in the prescription it was not mentioned for how many days to take. And the patient went into some sort of a scleral thinning. And finally won the case because they said in the prescription you have not mentioned when to stop mitomycin. Only thing, slightly it went into the favor of the doctor because this patient did not come back for follow-up. The court said there is a sort of shared negligence, but so contributory negligence. So that is where it slightly saved the doctor, but he was still held liable. So one is the documentation. The other one is when you have to talk about the visit. You don't just write 2 weeks and 3 weeks. You write 25th November, 2 p.m. which scale, whatever it is. And there are issues like I know a very senior ROP's physician in our country who has written 5th of April when actually he or she meant 5th of April, but the person was an NRI, and for him the month was written first. So he thought he has to come on 4th of May instead of 5th of April, you see, because they write the month first. And by the time that patient brought the child, a month later the child was blind. So these things can happen. These are cultural issues we may not be aware of, but then they go into court and then there's a problem. Failure to treat on time, failure to explain long-term follow-up, parent care, I'll leave that. Now how do you prevent litigations from screening? So the most important thing that we should do is apply the most current operational or guidelines. So for example, in anti-VEGF for adults, there is a VRSI guideline, especially came out after the DGCI banned Avastin and then reintroduced it. If any of us are deviating from that consent, it will be an issue. Not just for babies, but for adults as well. So like that, if there's an SOP given by the government, now there's always a hierarchy. If the government gives a guideline and a state society or a national society or AIOS or VRSI gives a guideline, it's the government one that will work. If there's a state society and a national society, the national society will work. So it is best to always have a unified guideline. That's why we have been working with VRSI and AIOS to have one common guideline and not something different for pediatricians and so on. Consent, documenting, counseling and so on, all of that is important. For one important thing here would be in ROP at least to have a card, the ROP card which you give the parent, that the duplicate information of that should exist with you. And a similar information should actually exist in the NICU. Because that's really important, because the pediatrician is then party to this case as well. Otherwise he'll be like, I referred to you, after that you took care, I don't know what happened after that. That should never happen, so you should maintain the duplication there. Treatment, ROP specific, obviously we're talking about consent here, use the correct guidelines. Anti-VEGF I'll deal with in 1 or 2 slides a little later. But these are the standard references that you must have and that you must be following. For example, this was the older one, we don't follow it anymore. We follow a national operational guideline. So if there's a Government of India guidelines, you must follow that. Not something that the NNF or the AIOS or the VRSI or the Indian ROP Society made, for example. So this probably I would keep for the ROP session, but there are certain protocols. So think about it in your specialty. What would you do? Maybe there is something like you have to give a drop or an antibiotic prior to a particular surgery. It could be. Maybe in LASIK surgery, maybe in cataract surgery, some of you all follow an NSAID drop before. Then if that is part of the protocol, I'm not saying it is, but if that is, then it should be done. So all of these things should be documented the way it is. And for a ROP, there are very, very standard guidelines, and any deviation from that will be a problem. There are still pediatricians who don't prefer 1,750 grams because they say, I got trained in Australia and there only 1,500 and less are screened. Well, that won't hold good in India, so you have to tell them that. So, for example, we have a rule saying before 30 days the first screening should be done. So these are very, very strict rules that we have to follow. And nowadays there's a deviation in that in the national guideline which says you have to screen at least once before discharge. Pediatricians don't know this. So you have to educate them. At the end of the day, we're not just saving our lives from litigation, but we also don't want babies to go blind. And now imaging. So there's a lot of apprehension, how can you allow non-doctors to take these pictures? So now this is part of the national guidelines. You can actually get people to do ROP screening through imaging. And you don't have to do it. You can train and accredit a non-doctor to do it. So this is part of a guideline. Again, not aware. We go to many northern states. South India is much better because the awareness is much better. You go to many northern states, they are not allowing ROP screening because they don't think it's even a problem. And some of them are like, what imaging? Call the ROP specialist. And there's no one there. And you're saying, you're talking about this. So, and this is another thing you have to tell the pediatricians. When the baby is good enough to be treated, when you can do the treatment when the baby is still housed inside an incubator, why are you delaying a screening? Because they are like, oh, this baby is very sick, let this baby come out of ventilation, then I will screen, then I will send you for screening after 2 months, 3 months. By then the baby is gone blind. So this is something that you have to tell them. And in ROP, at least do not discharge the baby from ROP screening at least till the child reaches 40 weeks. So because that is normal physiological vascularization of the retina. So if you are looking at 34 weeks and saying no ROP and then telling the parent you don't need to come back again, you are asking for legal trouble. I'm not saying clinical trouble, but you're asking for legal trouble. So documentation, as I was saying, keep one form with you, make a duplicate, all it needs is a carbon paper, and then if you maintain this ROP card, and then upload information if you're doing the telemedicine model, and so on. Now, what I'm going to now talk about is a little more broader principles because there are others as well. So the 10 commandments of the consent are here. So I think if you just look at these, you must mention complications. There's one case that went 50 lakhs against a LASIK surgeon, not because the complication was a displaced flap and an epithelial ingrowth. That was not the problem. The problem why he was held liable was because he did not mention dry eye as a complication then. And apparently dry eye is the most common complication of LASIK. That. But the courts knew that, and so 50 lakhs compensation was awarded because dry eye was not there in the consent, not because the flap was misaligned. So I'm just saying a complication because of your surgery going wrong. You've done a retinal detachment surgery, the retina does not attach, the eye goes into phthisis, not negligence. But if you have done something without following some of these guidelines, then negligence. So most of us think negligence, we use the English language word, It's like I've been negligent means something I did something wrong to them. That's not legal negligence. So, and then finally off-label. Now this ROP, when VRSI fought the ban and fortunately managed to reverse it, this was the case that actually prompted it. So there was this many patients who claimed 50 lakhs each, so it was going to go into crores of compensation, saying that there was an infected bevacizumab bottle. And then VRSI fought back saying, okay, they actually produced 2,500 publications across the world saying how effective and safe this drug is, and showed to the DGCI that if you ban Avastin and you allow only ranibizumab, plenty of our patients are going to go blind because they can't afford it. We are still a middle-income country. So what DGCI did was, they said, okay, give us the guidelines. So today what is available on the VRSI guideline is how to prepare that aliquot, what special consent to take. All of us should be following that because this is really on the tender hooks. Till today, it is still off-label. It is still off-label. It is not banned, it is allowed, it is accepted, it is respected, it has a guideline, but it is still off-label. And this becomes an issue when we are using it in pediatrics as well. And this is our recent publication on how we changed ROP practice guidelines during the COVID pandemic. I think India led it. We actually published these guidelines in March 2020, like literally at the end of that, beginning of that first wave, and then many countries followed what we were doing. And finally, indemnity, I think they've spoken about it, minimum of 50 lakhs, please. And I think if you are in the ROP practice, at least 2 crores. So IMA has it, there are professional bodies have it. What has been advised by lawyers is to break up your amount. So maybe a 20 lakh and a 30 lakh aliquot is better than a 50 lakh completely. And as again mentioned, the records, these rules keep changing, but minimum we must have as ROP physicians would be at least 18 years. And then give chance for that theory of discovery, because if the patient realizes that, oh, I became blind 18 years back because you didn't screen on time, then literally till 22 or 23 years of age, which becomes a problem for all of us because we'll have to keep records for so long. And I just want to end with the ethics. Right? We unfortunately or fortunately have in ROP practices where intravitreal injections are being given for just immature retina. And on the other hand, people who are not qualified are just writing no ROP, not referring to the people on time, not screening on time. So this is going to be really held against you, because today ethics is also under the law. It's no longer he's a good guy, he's not a good guy. Today he's violated the law, he's not violated the law. So that's all I want to end with.
Thank you. Anand, thank you. Yeah, exactly. Right.
Is that time? No.
One question, sir.
There's one question I want.
Yeah.
I mean, see, now we are giving, examining in the NICU, giving laser in the NICU. Now, is it necessary for us to make a file in our hospital regarding this patient, this child? Is it necessary?
No, sir. As long as the treating doctor has a consent directly with the patient, and you are treating it in the NICU bears the responsibility of providing, let's say, the oxygen and the monitoring, and you are going there as a specialist in the treatment. Your consent is with. What they might look at is, do you have an MOU with the NICU? So that I would think is a separate.
Yeah. Okay. Thank you, Dr. Anand, for enlightening us and